So it is week 8. I mean, we're getting really close. Week 10 is your exam. Next week's going to be reviews again. I do mine on Tuesdays for you. Is that a good day for you? Tuesdays, 5 o'clock for everybody? Or do you have a different time that works? Send me what you think. I mean, I can work around your times with most everything.
Yeah,
Now,
I'm in class till 4:30
all
or
right, so
5:30 your time. 5:30 your time.
so how about a 6 o'clock review? Okay, there we go. Tuesday, 6 o'clock. We'll do it then in Eastern time, which will be for everybody. Thank you. I appreciate the input, and I'll make those changes on my side. So this week we have that clinical pediatric assessment assignment. I've been telling you since the beginning, it's something you should work on because it's 3 sections. It is a 250-word APA paper. One of the things that I find that students don't do is put those little citations in the middle of a paragraph. Now, I've already had one student send me their paper, and I showed them how to put the citations in. So let's say you use the book Perry et al. Because it's more than one. It would be Perry et al., comma, 2022 in parentheses. And that's where you got your scholarly information from. Now, I can help you, your person in the LRC can help you, whatever you need, let me know and or send it to me and I'll explain it as I can. The second portion is that like about 11 pages of assessment. Most of it is circling. But remember, when you do your assessment, make sure that you're assessing a child with a condition that you are covering. Like if you're covering asthma, for say, those lungs, make them expiratory wheezing and make them labored breathing dyspnea and tachypnic, okay? So look at those things. If you're doing cystic fibrosis, maybe you have a distended abdomen because of fat ingestion, right? Make sure that the assessment fits your diagnosis. And then the third thing, teach me something. It could be how to give an MDI. I mean, you've done that on one of your discussion questions if asthma was what you chose, but everybody can't do asthma. Okay, I don't want more than 2 of anything. And that's why I said, let me know because I want a variety in the type of diagnoses that do come in. Also, it could be something as simple of ADHD, making schedules, showing me a schedule, showing me outreaches, type of what therapies, organizations that can help, autism, those things. Teach me something. 5 slides. I don't need anything big in a PowerPoint, or it could be a picture board or a pamphlet. So, but make sure you just don't copy a pamphlet or a picture board. Make sure that your original work is there, okay? So 3 components. You can send one at a time. Yes, Morgan.
Can you explain what exactly needs to be in the 250-word paragraph? Like, are we basing it off of the
What's the
assessment that we
diagnosis?
do?
No, what's the diagnosis? What is it? What is cystic fibrosis? What is asthma? What is ADHD?
Okay.
You
Okay.
might, some students do. It's this. I met a child, and this is what they showed me. If you have a child that you did see, that could be one of the paragraphs
Okay.
to enhance the diagnosis and give me more of a story. I've had it done both ways, Morgan. But thank
Okay.
you for that
Thank you.
question because both are right.
I have a question as well. So
Sure,
on
Kelly.
the 11 pages of an assessment, you said we're circling around to it. What do you mean by
There's
that?
circles. You circle which part of it, or you highlight whatever works for you. If it's lungs are clear, you can put clear. Abdominal, let's say
Oh.
bowel sounds. Which quadrant you
So
can.
there's a file to download with that on there?
It's in the modules, week 8.
Okay. I missed
You
that
go
part.
to it and you go and you can download it. Okay.
Okay, thank you.
No, you're very welcome. What else was I going to say about that? I'll remember in the end. So 3 portions, APA paper, the assessment. On the assessment, the most important part, believe it or not, is the last 2 pages. And it's on giving me NANDA diagnoses. You only need 2, okay? Because the rubric says 2. 2 NANDA diagnoses related to as evidenced by. I want to see those things in those diagnoses. And also you're going to have theorists. Like if you have a child with ADHD or autism, what do they show, right? What should they show? And then the right column is, how would you take care of that child in a hospital or daycare or whatever setting? What would you need to do to help them? And it could be things like with an autistic child, keep on a routine structure, right? Because they like that routine, or be aware of they don't like to be touched. Those things would be a part of that. So the theorists, Erickson, Piaget, what's the differences and how are you going to treat them in your clinical setting? Okay. Anybody who needs help with it, please just reach out. I will help you. You also have for week 8 your NCLEX questions and that pediatric assignment exam. And it's like 70 some odd questions, I believe. So take your time with it because we're getting you now prepped for the HESI. All right, because of all of these different questions. Now, on week 10, after the exam, I start an NCLEX prep. I have some extremely good information. I also, on a Saturday afternoon, right before week 11, will do what I call a HESI Q&A, where I take big, broad concepts and I make you think and make you understand. I've had students tell me they can hear me talking, taking the exams, because those concepts you will see. All I know is concepts. I don't know questions. I've never seen a HESI, but I know it could be something on hip dysplasia, or it could be something on thyroid growth and development. So I've figured out these possibilities, and the students tell me I'm pretty spot on. So usually if you do the HESI, you're going to do okay with it. All right, just to let you know. So next week will be your reviews. Week 10 is your exam. And then we're doing our HESI prep from there on, okay? Because I know some of those questions are going to be coming up. So let's go ahead and start today. My voice is a little scratchy. I don't know why. Maybe it's because my grandson was here this weekend, right? He always likes to share. Sharing is caring. So this week is a lot of information, and it's GINGU. And children have a lot of different diagnoses than do your adults, okay? So one of the things with these things is I did give you a handout, okay? And that handout goes over in the book all the diagnoses, and then I put a definition. I will give you the answer sheet after class when I give you your recording. So you'll have that also. This is actually a quiz I made up years ago for my students on ground. And students like to see all those diagnoses in one place because all those keywords are there and what you need to know. Okay, urinary tract infections. GU, children, urinary tract infections, absolutely. One of the most common conditions that kids get. And it's because of many things. Well, wiping the wrong way, not going to the bathroom, uncircumcised boys, because mom doesn't pull back the foreskin and clean underneath every day. And that's like a petri dish, that schmegma in there growing. That can be. Also, kids don't like to take meds. Many of them don't want to. And the parents are like, okay, the kid's fine, I'm going to stop. And they don't completely take care of the infection. That's one of the concerns. Now, how do you know a kid has a urinary tract infection? Well, these kids will be wiggling, they'll be touching themselves, they'll be running, okay? But also, if a kid is potty trained and all of a sudden they're starting to more than once be incontinent, something's going on. And then, of course, the smell, if it smells bad, of course, you know that. So, as nurses teaching parents about things like urinary tract infections, it's that earlier that we catch it, the better it is for the child and for their kidneys, right? Simply teaching them washing hands, after they go to the bathroom, wiping from front to back little girls, little boys pulling back their foreskin, cleaning underneath every day. And then adolescents, I know that we're not supposed to teach that they can have sex, but adolescents are going to do what they want. If they are getting frequent urinary tract infections, and as a nurse, you find out that it is because they're having intercourse, tell them to urinate immediately after intercourse. That has decreased the incidence of urinary tract infections. So we've decided that a child has a urinary tract infection. There's all different ways that we can go and we can look for it. And we know the younger the child, the more important it is to get an accurate urine specimen the first time. That's why we promote in the first year of life, because their immune system is so low, to do a straight cath. Parents don't like it, but we're saving this child multiple visits. We're saving kidneys because we're not letting that bladder go up and now into the kidneys and destroy kidney tissue. So we do a catheterized urine on young infants. Now, if the kid is a premature infant showing signs of sepsis, which is usually as simple as apneas and bradycardias, that's what they show with sepsis infection, we're going to do something called a suprapubic aspiration. And they take right above the symphysis pubis bone, they clean it, sterile gloves, they use a needle and a syringe, they stick it in and pull out a small little specimen of urine. And that is sent for a urine CNS. Because there's no small enough catheter to go into a premature infant. And I don't know, but it's like looking at a tiny thread and some of these tiny ones. You can go into the kidneys, do the taps there. We could do bladder washouts. Older kids that are having chronic infections, we might look at ultrasound or voiding cystourethographies, which is we're looking at obstructions. Is there an obstruction? Is there a kink in a ureter? Is there something wrong with a sphincter? Those things. As we get older, maybe an IVP, an intravenous pyelorography. This looks at kidney stones, right? And then renal scans also can show some structure in stones, etc. Now, many times we can do a renal biopsy. This could be the kid who's chronic polynephritis, right? They're always with fevers and their kidneys are being hurt. We want to go right to the kidney, see what infection's there, and we do that by doing a renal biopsy. Now, this is like preparing for a surgery type thing. Depending on the age of the child, there'll be NPO. Infants, 2 hours. Older children, 4 to 6 hours NPO. You pre-op, you do the procedure with a physician, or you're sent to a procedure room. And when they come back, we'll do vital signs. Now, we have stuck a needle into the kidney, into the back. Two things can happen. We can bleed or we can pass urine into the peritoneal cavity, or it could be oozing out onto the bandage. So that's why we need a pressure dressing, just like a cardiac cath, right? Or a sandbag, if possible. They are on bed rest 24 hours. Again, hopefully that there was a clot formed over the area where the needle was stuck and we're not going to ooze, but getting up earlier than that, it could dislodge it and then do this urine or bleeding into the bladder, into the peritoneum, etc. Okay? So smaller kids, they do an incision. So that one will even look for the incision site, etc., because you can't really see it. Now, I mentioned this voiding cystourethography, and this is all about structure. Something's wrong, and it could be one side, two sides. It could be just one of the, sphincters, or it could be a lot more. So you've got these pictures in the book, and it shows you. Just remember, the bladder is called a vesicle. Okay, and then you have your ureter. So it could be a vesicle uretal. That means somewhere between the bladder and the ureters, there is some sort of kink or that that valve is not working well. So vesicle is your bladder, and that's the one thing word I want you to be aware about. Now, nephrotic syndrome has nothing to do with renal failure. I'm going to say it again because students make this error. Nothing to do with renal failure. Your kidneys are working. But what the kidneys say is protein, yuck, I don't like you, and it spills it out. So what are you going to see? Protein's going to come out in the urine, and protein levels in the body and the blood is going to go way down. And because now you've changed the status of the intravascular, extracellular, fluid gets pushed out into tissue, and now you have generalized edema everywhere. So you lose protein in your urine, proteinuria. You lose protein in your blood. So again, you have to be careful on giving medications now, because remember, protein has to do with drug doses, and we don't want to have too much or toxic. Put these children in toxic shock because of too much medication in there. So again, nephrotic syndrome's all about protein loss. So it is lifelong. It is an immune state. It's an autoimmune state, and it's going to be treated forever. One of the things is with any immune disorder, worry about infection, washing hands for sure. When their mouths swell up with all this edema, they're not going to want to eat. Now, they're going to have to be on salt restriction and fluid restriction, because we don't want to cause anything to create more edema on it. And the whole family needs to understand this. Brothers and sisters with a salt shaker. You know how kids are, I got salt and you don't. So things like this need to be explained to the families. So how do we take care of it? Well, we're going to be trying to do everything we can to stop it. Steroids are what we do for choice. And steroids create fluid too. So it's one of those, we try to calm down the kidneys, stop it from losing proteins, but with the fluid restriction, the salt restriction, and we're going to, of course, wash our hands, prevent infections. And with anything that has to do with fluid and fluid balance, the way we monitor our progress is I&O and daily weights, because we want to see if they're gaining weight, they're holding fluids, something's going on, all right? And if we have too much intake, not enough output, same thing. And that's another reason why we weigh our children every time we see them, no matter what. Now, acute glomerular nephritis. This is just like rheumatic fever. This is another strep infection. The strep infection goes and we don't treat it completely. Sometimes it sits there for a while, up to like 3 weeks, and then all of a sudden you stop urinating. You swell up, you have high blood pressure, and you start seeing what we call periorbital edema. And then because all of this fluid, blood pressures are up because you're not urinating, and all of this edema, headaches. And those headaches really need to be closely monitored because it could be hypertensive crisis. We might have to give medications for that. With this glomerulonephritis, due to a strep infection that wasn't treated, you're going to see also urinary tract is going to be given urine, but it's going to be a red-brown color. And of course, there's going to be increased protein in this urine. Now, if it's due to that strep infection, we're going to treat the strep infection also, just like we did with rheumatic fever, and hopefully it completely resolves itself. Usually the headaches, not urinating, the swelling brings them into the physician, and the physician will see it. But if it's left too long, it can become chronic, and then you're chronic glomerulonephritis, which will be lifelong treatment. So you're retaining fluids, right? So what do we need to do? Daily weights, intake, output. And we're also going to be looking at that abdomen, making sure if there's any fluid in there. Again, low sodium, fluid restrictions, and they're also susceptible to infections. You can see the similarities there between both of those. One's due to a strep infection, and the other one's just a syndrome that occurs that cannot be cured. Glomerulonephritis can become acute, and we can cure it. We've talked about Wilms tumor already. It's part of it because it's on the kidneys, and that's why it's here. And we know it's do not palpate that abdomen, and they can take it out. Now, renal failure. Children can be born with kidney issues, or they could be born with normal kidneys and something happens. Could be obstructions, could be infections that causes acute renal failure. I've actually seen ibuprofen taken too many doses for a couple days create acute renal failure. And then they stopped the ibuprofen finally in the hospital when they got there. And 3 days later, they started urinating. All of a sudden, the ibuprofen went away. So acute could be many things. So acute renal failure is basically all of a sudden you stop urinating, right? The biggest thing, yes, it's due to meds, like I just said, but the most common is dehydration. When you don't have perfusion of the kidneys say, I'm not happy, and they shut down. And it's just the body's defense against not enough fluids. So dehydration in children is very serious. Chronic renal failure is when over 50% of their kidneys aren't working, and it progressively gets worse and worse and worse. It's called uremia. It could be due to many things. It could be due to congenital problems, urinary tract, reflux, always going into the kidneys and damaging them, pyelonephritis, glomerulonephritis, or it could be that lupus attacking kidneys, or how about an anaphylaxis shock that kills the kidneys? There is some hereditary disorders. I've seen it where I was asking the nurses on the hospital where I was working as a clinical instructor, why are so many children with chronic renal failure requiring dialysis? And their answers, more than one nurse, was they were having some cultures were marrying cousins. So it was that created hereditary disorders. So I was like, okay. And then you went and you looked at the children, and you're like, well, maybe it could be. I don't know. I'm just saying what nurses have told me. So how do we manage renal failure? Well, we want to try to get that kidney working as good as it can. We're going to remove the fluids. Some sort of dialysis will be done. This is a hemodialysis that we're seeing here. We're always worried about fluid electrolytes. Adults, children, it's the same. And also we know erythropoietin is in the kidneys. And when your kidneys don't work, you're not forming red blood cells. So we might, and probably are, giving erythropoietin injection, sub-Q, to these children. So the body itself can produce red blood cells. Chronically, these children live on a low hemoglobin hematocrit. So they're going to be not as much energy as a child with a normal hemoglobin hematocrit, right? Another thing is we have that, hemodialysis, and then we have peritoneal dialysis. Now, I had never seen peritoneal dialysis, and when I first started working at the hospital here next to me, I was in the newborn ICU, and I had a child whose kidneys wasn't working through a condition called prune belly. And we had to put in a peritoneal dialysis catheter. Well, they just so happened to have a peritoneal dialysis class the next day. And I went to it to learn because I always want to know. I just don't like to look at it. I want to know and how these things work. And what happens with peritoneal dialysis is there's a tube that goes into the abdomen, and we need to protect that sterilely because your peritoneum now is your kidney. We don't want any infection getting in there. So sterile technique is important. when we starting to see a reddened abdomen or exudate or a different color fluid coming out, we're going to call the doctor. Most likely, it's the beginning of peritonitis. We need the doctor to order some antibiotics on it. So what we do is this is the way that they are normally, and usually we'll do a catheter at night while the child sleeps, and it can be done at home, which is great. And there's a warmer that we put this diastolate, the fluid, on, and the nephrologist orders it. It's all different, whatever it needs, whether it's electrolyte, sugar, whatever it is. And they put it a certain quantity we call still. We insert that amount of fluid, 100 mLs likely on a small infant, and we let it sit there and we let it still in there. And then 20 minutes, half an hour later, we drain it. So we put in, it sits and drains. And we do about 8 to 10 of those cycles at night. And when you're done, you can measure the urine because it's going to go into a Foley bag. We're going to be measuring what's in there and subtract it from the amount of times that 100 mLs went in there. And that's your urinary output. So it works well. They're using this a lot on adults too, versus going directly to hemodialysis. It keeps adults home, which is what we want. But the biggest thing is infection, peritonitis, somebody who doesn't know what they're doing, trying to hook this machine up. All they're going to do is create, infections on it. And again, any change in that color or the tenderness of the abdomen, etc., we need to immediately call the doctor. So what is acute glomerular nephritis? What is it? Anybody?
B.
Yep, it's another strep infection. Sure is. Okay, GI. You're going to hear some things probably you've never heard of before, but let's start with stuff that you know. Well, we know nutrition is a big thing in children. And we know if they don't get nutrition, they're not going to grow. There are some conditions that really work on how do we give nutrition to that child, right? Whether it's cancer, they don't want to eat, HIV, they don't want to eat, sickle cell, we want to give that high protein, high carbs. Same thing with cystic fibrosis. And what about a tiny little premature infant? How do you give the calories you need in that smaller quantities, right? All of these things create problems. So remember, it is thinking of that. Now, celiac disease is a problem with the intolerance to something called gluten. Gluten is wheat, rye, barley, and oat flour. It's on everything: bread, cakes, cookies, breading, macaronis, spaghettis, all of that. One of the good alternatives to that is rice, and they've got rice flours too. And we're lucky today because there's more of these foods around than they were, when I was a kid. So it's a good thing. Now, what happens with gluten is they don't absorb fat. And it's all in the small intestines with all the absorption going on. So they're losing fat vitamins. They've got what we call steatorrhea, which is a very unbelievably malodorous. It smells horrible, pale, bulky sort of stools. It's just, CF is more of the fuzzy, you know, type of stools. This is more bulk, but it stinks and there's no color to it. So you're going to see with fat problems, you're not digesting, you're going to have that big abdomen because it's gassy to them. And they're going to probably have a lot of gas also, along with these terrible stools. Now, food allergies. We know that when your infant 6 months old, we start to feed them food. And one of the things we do is we wait 4 to 7 days in between the introduction of a new food source. And it's because we're looking for food allergies. It could be as simple as a little vomiting, diarrhea, abdominal pain, rash, but they're all different in children. Now, if we had a lactose intolerance, the one thing we have to remember is, well, foods we can switch for other things, but milk, we need them to get their vitamin D and their calcium. So these might need to be supplemented, right? In a lactose intolerant child that's not getting them in any other sources. GI dysfunction could be many things. Well, we know if we're not tolerating food, we know that there's going to be some sort of growth failure, probably some cognitive problems going on. It could be spitting up, regurg, it could be nausea, vomiting, diarrhea, constipation, but it could also be something from the liver and jaundice, or maybe they have a trouble with eating. Pierre Robin, it's a big thing with a tiny jaw. DeGeorge syndrome, they can't swallow. They don't know how to do it. This dysphagia, and they have to be taught by speech therapy. It could be the only problem. And remember, fever burns up fluid. So then we worry about dehydration. We don't think of that, but children with fever need a little extra fluid. So dehydration, right? It's when you have too much out and not enough in. Could be due to many different things. As I said, it could be that fever. It could be due to all of a sudden the urines are urinating a lot. The kidneys are just going for, we know there's some endocrine things that can do that. Of course, vomiting, diarrhea, diabetes, ketoacidosis, you're getting fluid out. And then of course, burns. Absolutely, it's has destroyed tissue, and in tissue is fluids. Now, I like infants that are dehydrated because it's easy to see. It's a visual. Look at that kid in the top picture. Look at that fontanelle. But besides that, look at the color of that child. That is pale. Even the ears are pale. And you can really see just by looking, this kid looks dehydrated. What else would you see? Elevated heart rate, decreased blood pressure, prolonged capillary refill, no urine output. Children who are dehydrated, infants, they're going to cry. No tears. It's the saddest thing to see an infant crying and there's no tears coming out. You know they're in trouble. And then infants also, skin tinting that you would see. You don't see that as much as adults as you will see with an infant. So how do we take care of this? Well, if the dehydration is severe, like these two infants look like, this one's going to get an IV. And as we're putting the IV in, we're going to do a basic metabolic profile. That's going to confirm our condition with all the other assessments. Always remember, when we have dehydration, we can give boluses of fluid. Make sure that if we're giving potassium, that child has voided, or we have a potassium level on that metabolic profile. It is dangerous to do it without. So we always say no potassium in a bolus ever. And then you can't hang it, that IV with potassium, until you see urine or you know the potassium level. If the kid is vomiting, of course, give that anti-emetic. And then, did it work? Did that fluid bolus help? Well, we're going to see all the changes in the assessment, but what about it's 2 days later? They're in the hospital. What's the weight the child came in? And what is the weight today? You should see a weight gain, wouldn't you? Again, height and weights do a lot, don't they? Measuring intake and output, we're looking at urines and stools and vomiting. Usually we don't measure sweating. Usually it's not that severe, but we can, if we had to, put a pad underneath them, know the weight, take it off, weigh it, and we know the difference. Usually it's the vital signs, skin turgor, mucous membranes, looking at their weights again, fontanelles, as I said. And remember, if a kid doesn't have enough fluids, they're going to have decreased perfusion in the brain, and they're not going to be as alert. They're not going to be, answering questions as much, and they're going to be really disoriented. Now, diarrhea. We don't always have to give IV fluids. because if they're not vomiting, we can put it in the GI tract. It could be acute, chronic, it could be infectious, whatever, but our treatments are all about the same. If we have the diarrhea, we can give oral rehydration therapy, Pedialyte, Gatorade, Powerade, and small sips, we can get it down. In the hospital, they're going to give you lactobacillus, which is just replace the flora in there. That's all they do. Again, we can assess it if we need to by looking at a electrolyte panel. And then after we get that fluid in there, whether it's oral or IV, I mean, if they're, really out of it, we're going to start an IV. If the vital signs, the heart rate on a 1-year-old is 200, we're going to start an IV. But it all depends on patient condition. But again, we start to introduce that diet, and we start slow. We used to have this thing called a brat diet. We don't say that anymore. We just say start with easy stuff, but it's still bananas, rice, applesauce, and toast. They all work, with most children. Now, constipation in children, many times it's nothing to do with something with the body. A lot of times it has to do with stress and what's going on around them. It could be due to they had to move, their best friend moved, their cat died, grandma, died. It could be all of this stuff, or there's a bad home environment. And a lot of times you'll see children with constipation in the newborn period. And I've mentioned this, that hypothyroidism and cystic fibrosis all do not have a stool in the first 24 to 36 hours. It also could be due to a kink or a non-opening in the intestines and something called Hirschsprung's. We're going to go into what that is. This is the stool you should see at first. It's called meconium, and it's this green, gooey, black, sticky stuff. And that's a normal stool. Now, constipation in infants, we usually do not see it in that child who is breastfed. They usually have more stools than the child that are formula fed. Now, in the older kids, we can start whole grains, actually black beans. I was reading that, and I put that in there for my Miami people, the Hispanics like me. My children are half Hispanic, so I put it in there. But usually with constipation in infancy, you're not going to give enemas. We're not going to give medications. Usually on an infant, the doctor might say, give a little prune juice or give a little bit apple juice, something simple before we go into anything more involved than that. Now, enterobiasis is another word for pinworms. This is those kids who play outside in the dirt with nails that the dirt collects, and then everything's in the mouth, right? And now the worms are in their mouth. And now at night, they're not sleeping good. They're keeping everybody awake, and their anus is itchy and scratchy and driving people nuts. That's basically pinworms. So we need to teach our parents how to collect them so we can identify the worm and give the proper medication for it, because there's medications for it. So at night, you use a flashlight, you go in and check their anal area. And this is the size of them. They're little and they're tiny. They also will take Scotch tape and just put it on the anus and get it on the tape. And then we'll tell them to put it in a jar or a baggie or something to get it to the doctor. And if one person in the family, if that kid has it, you need to check the whole family, because it is passed from family to member to the family member. And one of the ways that we can prevent it is keeping kids' nails short. And the dirt can't get up underneath. And of course, hand washing, right? So children can get peptic ulcers. And, you do have children who do worry a lot, right? They're always worried about mom and dad and grandma and grandpa and whatnot. And they can get that upset stomach, with that little bit of pain. And usually what they'll do is just something that's more medication. I mean, the book says Zantac, but Pepcid is the recommended, not Zantac anymore. And all it does is reduces the amount of gastric acid that's produced. Now, if we need to, and I've never seen it, believe it or not, a child who had such a bad ulcer that couldn't be corrected by diet or medications that needed to go and have a partial gastrectomy, that's usually your older adults. Liver disorders could be due to many things. Could be viral, non-viral, autoimmune, that lupus going for you again, some metabolic or some reason why that liver's not working. Well, what we need to know about any child who has diagnosis hepatitis for whatever cause is that they're not digesting fat. So again, high protein, high carbohydrates, that's for your nutrition, right? And if we're giving these children fat, again, their abdomens will get enlarged and they'll be full of gas and gas pains. So we need to be careful with the amount of fat in their diet. Hirschsprung's is the other disease that causes constipation in the newborn. And that picture is probably a radical one, but it really delivers what I'm talking about. The descending colon has no nerves in it, aganglionic, no peristalsis, no absorption. All the food, all the intestine contents sit there. It gets bigger and bigger. There's no nerves, they don't feel it. And then you can see that bottom little thing that hangs down that goes to the rectum. Sometimes a little bit of ribbon stool comes out, sometimes nothing. So it's called an aganglionic megacolon. There is intestinal obstruction going on in there. You're going to see the abdomen get enlarged. They don't feel it at all. And as I said, might have those little ribbon stools. Now, once we see that, let's say a child comes in, an infant, has not stooled, we'll be carefully assessing for these things. They'll just do a regular x-ray to look first to see that abdomen, making sure it's not Hirschsprung's. Then they'll be testing for cystic fibrosis. They'll be testing for hypothyroidism, and whatever the cause is, they'll treat it. Now, if we decide that it is Hirschsprung's, first, we're going to do a little rectal biopsy. It confirms that biopsy has no nerves in it. All right, that piece of bowel is worthless. They will do an x-ray, barium studies, and then they do this two-part sort of thing. Usually, they'll take that piece of intestines that doesn't work, and they'll take it, put the good piece up to the abdominal wall for a colostomy, usually. Later on, they'll go back and reconnect it. But they can do a pull-through procedure where they remove it and immediately connect it. Depends on how much intestines was involved in it. Some of the precautions are no rectal temps. Once you know Hirschsprung's, leave it alone. And then when they are post-op, it's 2 to 3 days before we even feed them. I didn't put days in there, but it's 2 to 3 days where they have to rest that intestine, and keep it empty and let it heal. And then we'll do slow introduction of diet. Appendix, just like an adult, right lower quadrant, McBurney point, rebound tenderness, right. So kid comes in, you can actually see these children, a lot of them will walk in, bent over, hand on that right lower quadrant, and limping on the right leg. You're like, ooh, that's an intestines. And that's going to be my appendix there. Something's going on. And you go in, you do your assessment, and you see it, yes. Well, immediately you tell the child, no, and the parents, please don't feed him anymore until we get an ultrasound, we figure out what's going on. We determine that it's an appendix, they need surgery, and we go up as quickly as we can. We'll start IV fluids. We're going to probably give an antibiotic just for precaution. And this one hasn't burst. This is just a regular appendix. And if they're on pre-op meds that have to be given, we will give them. We don't want to stop any normal orders that a child is on. Now, what if it bursts? The pain is gone. That's the one thing. Pain is gone, but now the appendix is burst. It's spewing contents into the peritoneal cavity, and this child is going to be sick post-op. So post-operatively, that intestine has all this stuff, this debris, which has spewed all over those intestines, and they're angry. So we've got to keep them deflated. So NPO and an NG tube, even that gastric acid upsets them. And we're just going to keep it, that intestines empty. Now, they'll be on IV fluids, of course, IV antibiotics. We'll be monitoring those lab results. That CBC initially is going to have a high white count, and we should be watching it come down. We also need to watch electrolytes because of the NG tube suction, right? So we'll be monitoring that also. Pain control is absolutely needed. Post-operatively, they're hurt. They do a lot more manipulation in a child with a ruptured appendix, okay? And then the other thing we forget is that wound is in an abdomen that was completely infected. So you have attached and sewn up an area that has potential to dehisce because it was infected. So checking that wound, very, very important because it can and it will open up. Now, post-operatively, we got to give good pulmonary care. Medicate them for pain before, get them up, get them out of bed. They can ambulate. We can clamp the NG tube and walk them around because we want those lungs and no other side effects from the surgery. One of the things, I've done a couple different things for pulmonary care. You can have them blow bubbles. They're great. They're deep breathing, right? Blowing. Or one of those pinwheels on those small kids. I had an older kid that I had to do good pulmonary care that I gave him a straw, and she was like 14 at the time. Would take a little piece of paper and do a spit, and we'd had a target set up across the room and seen if she could hit the bullseye. This was a post-trach transplant, so she really need to keep that air moving, and she never had atelectasis in her lungs because every night I came in, me and her would have a contest who could get the bullseye. So little tricks work. Now, an omphalocele is a child whose belly button didn't close and now the insides are coming out. It could be the intestines, liver, stomach, anything, all coming out. That's actually a small one. It could be even enlarged, and it's usually a sac around it, okay? We need to make sure at birth that we cover it with a sterile dressing and normal saline. Surgery is going to come in, and they do something called a TP, where you hang it from an IV post and hang it up. So, and they're going to be on their back, supine. These kids can't be turned. These kids are not going to be swaddled. They can't be held. They have to be in that warmer, heated warmer to keep them warm. Because look, her insides are out. We need to keep it all warm, right? And it sort of slowly will go into the abdominal wall. And eventually, could be a week, could be less than, the surgeon has made enough room, and then they close it. And they do okay. All the insides work. It's just on the outside, okay? Because of this, they will be NPO, and they will be getting IV fluids and antibiotics to prevent infection. So that's omphalocele. Now, intussusception. These are your young toddlers down to 3 months. The youngest I saw was 5 months, and it was very difficult to diagnose. These children all of a sudden scream in intense abdominal pain. Their legs are just, and you can't console them. I've seen them come in like that. I take my hand, put them on their abdomen, and it's tense. That's usually the kicker. This is intussusception. Now, if you look at their diaper or look at their underwear, you're going to see a currant jelly with a little bit of blood streaks in it. That's sort of like the way it's squished in, it pushes it out the rectum. You're going to see that. So we do an ultrasound. And many of these children, before they get to ultrasound, their pain is gone. What happens, it can go in and out like a telescope. And what we'll do is we'll send them home and to take increased fiber in their diet. Now, if these children don't, if it's in there and it stays there, we can't get it out, they'll be sent to radiology for a barium or an air enema under fluoroscopy with radiologists there. And they could squirt air in there or put the dye in there and it pushes it open. And that sometimes can relieve it. If not, they're going to have to go to surgery and have a colectomy. I've only seen one go for the colectomy. A meckel diverticulum. There's some sort of, in the small intestines, there's an area that protrudes inside, and in that protrusion is a big blood vessel. And something happens and it rips, and you don't really feel much. Maybe some slight tenderness around the umbilicus, but not really. But what you'll see is rectal bleeding. Now, what we do is we figure it out, what's going on, and then we go to surgery, take out that duct, and these kids do great. IBS. IBS is mouth to anus, right? Ulcerative colitis, Crohn's disease. I mean, ulcerative colitis, some of your signs and symptoms could be profuse diarrhea, or it could just be abdominal pain, nausea, vomiting. Many times with IBS, it is nutritional support, steroids, a lot of the times, and if controlled, they can do okay. But with this, again, autoimmune, we have to be worried about infections, and these children must be on this diet and be very careful, or they're going to suffer it. They'll feel the consequences when they don't do or eat the right stuff. Now, short bowel syndrome, usually it's due to that child that has had a piece of their bowel removed for certain reasons. Could it be that Hirschsprung's? No. Usually it's the upper small bowel. I've seen it happen with something called necrotizing enterocolitis, and that's your newborn. Sometimes you start feeding newborns and they don't tolerate it. Whether it was from a hypoxic, anoxic episode at birth, they don't really know, but there's no blood and that bowel dies. And then you put food in there and it just doesn't like it. And you'll see the abdomen get distended and there's actually ripples. This is why we do abdominal girths on every feed on a child in newborn ICU. We're making sure that their bowels are working. The treatment for necrotizing enterocolitis, or NEC, they do surgery and take that piece of bowel out. I've seen it done at the bedside. Another thing is gastroschisis. Well, this is part of the other one where some of their insides are on the outside. It could be called gastroschisis, just to put it in there, part of it. What we do for these children, I had a little twin, a triplet, who had cardiac surgery, had NEC, had 58 centimeters of her small bowel removed. She went into severe nutritional problems. So she had a central line. She had hyperlipids at night. She had a gastrostomy tube, feeds during the day. And I met her when she was 18. And this girl was skinny, but She started to eat by her mouth too with the gastrostomy feed. So it's all an absorption nutrition problems. And yes, she did have some cognitive delay because nutrition, right? Hernias can be anywhere. They could be a diaphragm didn't close, that the intestines are in the chest. That's a severe emergency. Sick infant. Could be the umbilicus. If you can push your finger in and out softly without pain, it's fine. But if it turns red, hard, tender, painful, it's either an incarcerated or a strangulated hernia, and we need to untwist it so it doesn't die. So immediate surgery. Imperforated anus. Not everybody's born with an anus. I honestly saw one in all of my career, and we have to do something because the body has to eliminate somewhere. So again, they do a colostomy on these children, so there's somewhere to go. And eventually they do multiple surgeries to try to make an anus, which is most ideal thing to do for them if we can. At birth, they can have fistulas, and many times it's nurses who find it. We can see stool coming in from the vagina or urine coming from the anus. We could see even stool coming out in the penis and the urine in the male. I mean, these are things, or fistulas, that we're not expecting it. So it is looking what's going on there. Children eat everything, right? What are the lead? In younger children, they bite on the window sills. In an older building, could have lead. That's the pica thing that goes on. They're all dangerous. Children put everything in their mouth. I've seen rat poison to meds to children. They love their Flintstones, chewable vitamins. Again, all of these things is teaching these parents, to protect their child. Children can vomit for many reasons. It could be just reflux, or it could just be, they got that bug from daycare, right? And, nausea or not depends on the kid, can tell you. They have to be old enough to tell you that. It could have bile in it or not. Now, if they're vomiting and you're uncontrolled, this is something that you're going to need an IV with. And the way that we diagnose, again, is a metabolic profile. And we give an IV bolus. Again, never with dextrose, never with potassium, but usually it's normal saline is our drug of choice. And we're going to keep them NPO and, of course, give an antiemetic and try to wait because we don't want them dehydrated. Now, gastroesophageal reflux, GERD, very common in the newborn. Children tend to have this little spit up going on, and, we'll do everything to try to stop that spit up. We'll try to decrease the feeds if we can, burp them well, sit them up, give them medications, all of those things. And if they still continue and we can't stop it and they're not gaining weight, nutrition is suffering many times. They might consider a surgical intervention. And this is the more severe case. And what we do is something called a Nissen fundoplication. And this is used for children, adults, getting a gastrostomy tube. And what it does, it kinks the stomach with the esophagus so you cannot vomit. So all of that burning of the esophagus stops. It keeps the food down. And that's a Nissen fundoplication. Now, older children, all of a sudden you might see them refluxing. All of a sudden they got this chronic cough, and you're like, why? And then they start with heartburn. It's probably reflux. Again, same treatment. Try to do diet, try to do medications, and then if that don't work, the Nissen fundoplication. Now, hypertrophic pyloric stenosis. The pyloric valve is at the opening from the stomach into the small intestines. And it gets thickened, muscular, and milk cannot go down. Even milk can't go down that valve. So the stomach fills up, fills up, and then all of a sudden, point the kid 10 feet from the garbage can, and they're going to throw up forcefully across the room. It is not a dribble. It is across the room. Be careful. They will get your shoes. I mean, it is intense the way that they will vomit. So any infant that comes in 3 months, 3 weeks to 3 months, they tell me they're vomiting, I'll say, are you dribbling or are you across the room? And if they say forcefully, I'm going to take my hand and put it underneath their xiphoid process, and you're going to feel this olive size or a marble size mass. And you're like, pyloric stenosis. Tell those parents, please stop feeding your child. They send them for an ultrasound, they find it, and all they need to be is stop them eating and just replace their fluids, and they'll go to surgery. Once surgery is done, usually we'll just start with clear liquids, and these kids do well. This is only the very, very young children. Can you imagine your infant at 3 weeks to 3 months vomiting like that? And then saying, oh, you got to go to surgery. So these mothers need a lot of special attention. Now, cleft lips can happen where one side, both sides, it could be the palate, the lips, and the lips, when it is just the lip, we usually will close it about 2 to 3 months. Because what do kids do to soothe themselves? They suck, right? So with a cleft lip, can they suck? No. So you can imagine these sort of issues that we're going to have here. They can't eat, they can't suck. It's going to be a feeding problem. Breastfeeding is almost impossible. And then let's say we have a palate problem. It's the roof of the mouth, it's not closed. And everything with these lips and these palates, if we don't take them and close them surgically early enough, they will have speech problems. I know some older nurses that I worked with who had bilateral clefts. Till the day she retired, you could tell the garbled speech because of a cleft problem. So it can be lifelong. So cleft palate is closed between 6 to 12 months, and the lip only is 2 to 3 months. This is called a Haberman bottle, and the top is soft. So we put it in the mouth, and they sort of clump on it like they're sucking, and you just squeeze it little by little, and they think they're sucking and they're swallowing. Breastfeeding on a parent is they almost have to squeeze the milk into their mouth. It is an absolute chore for that parent because you're not going to close it till 2 to 3 months, okay? And then nutrition, growth problems if we don't get it. Tracheal, esophageal fistula, esophageal atresia is all about problems with the esophagus does not attach to the stomach, so it goes down and comes back up. Also, sometimes there's a hole between the trachea and the esophagus. So you swallow down the esophagus, it goes directly into the lungs. These children usually, many times we don't know this is going to go on. And then what happens is they're sitting there and they've got mucus and they're coughing and spittering and sputtering and they're getting a little blue. And then we try to feed them, let's say the initial little dextrose water or something, and they're aspirating and you hear them, coughing and gagging. That's our only suspicion to start with. Now, this is always having mini aspirations, right? No matter what, your mouth is producing saliva. They're swallowing saliva. They're chronically swallowing these things. So, number one, nothing by mouth, because all it's going to do is go into the lungs or come back and go into the lungs. And we're going to be given antibiotics because of aspiration that's going on, okay? These kids are usually mentally normal, but these kids need this repaired and they do well. Our goal is to prevent those pneumonias, to get them to surgery. If they can't do surgery right away, they'll put in a gastrostomy tube, and we'll be teaching those parents. You'll have suction at the bedside, sleeping, with their heads elevated more. Those things will have to be done. So this one here, I mean, the kids will be fine besides that, but they're just aspirating on, even their own mucus. Any questions? A lot of different stuff in GI and GU, isn't there? Things that like, what is that? So something that you should look at, try to fill in that paper and it will help you. So who wants to win the Kahoots today? Kayla, it's your turn. I saw you smile. All right, go for it. All right, let's get started. Week 8, GI/GU. I'll multi-select. What are all the following symptoms of dehydration in an infant? I mean, I wish Fontenelle was there, right? But when you talk dehydration, infant, child, adult, all the things are the same. The only difference would be that sunken fontanelle in the infant. They are going to have decreased urine output. They're going to be weak, lethargic. Older kids, cognitively, they're not going to be with us. They're going to be a little confused. That tenting of skin, right? The loss of elasticity, dry, pale skin, elevated heart rate, decreased blood pressure, prolonged capillary refill. I could go on and on. Dehydration is a huge concept. What is priority treatment for a child with dehydration due to profuse vomiting? So remember, when you talk about vomiting, diarrhea, it all depends on patient condition, right? Do I give them oral? Do I give them IV? What's the most appropriate? With profuse vomiting, that kid is sick. That one's going to get IV fluids, okay? Are you going to maintain them NVO? Of course. You're going to give antiemetics? Of course. But your biggest priority is IV fluids. What is the treatment for an infant with diarrhea lasting for 4 days? They have diarrhea. What are you going to do? Well, if you have diarrhea, it means you still can drink. It's not diarrhea and vomiting, okay? Pedialyte is fine, unless the child is showing many of the other signs and symptoms of dehydration. But just normally, a child would get oral, which would be Pedialyte, okay? What acid-base imbalance might you see with a child who's having profuse diarrhea? Now, on the HESI, one of them had 4 acid-base questions. What was vomiting? What do you see? Diarrhea, what do you see? Hyperventilating, what do you see? So when you have diarrhea, diarrhea is full of alkaline. Think about all of those enzymes for digestion are all alkaline. So when you have diarrhea, you're losing alkaline. What do you have left? Acid. So that's metabolic acidosis. Now, vomiting, you have gastric acid, right? You're vomiting acid. What is left? Alkalosis. That's the difference between the both of them, okay? A multi-select. If an infant has not passed the meconium stool within the first 24 to 36 hours, what would you assess for? Hypothyroidism, cystic fibrosis, and Hirschsprung's. Electrolyte? No. There's no reason to lose electrolytes with not having a stool. A deficiency of vitamin D. What does that cause? Vitamin D and calcium. Remember that was one of those lactose intolerance vitamin deficiency? What is the name of that one? Remember, vitamin D has to do with bones, right? So rickets. Scurvy is vitamin C. So those are the two that were there. A multi. What treatment can the nurse anticipate to a child unable to drink or eat anything with profuse vomiting and diarrhea? We know that we're going to do a metabolic profile. We're giving nothing by mouth or profuse vomiting and just going to vomit some more. So NPO, start an IV and draw that basic metabolic profile. And that's what you do. And of course, with the vomiting, they'll be given the antiemetic, waiting and slow introduction of food. Diarrhea doesn't stop eating food or drink. It's the vomiting. Rest that stomach a little bit. A multi-select. What nursing management would you anticipate for a child with a ruptured appendix post-operatively? Remember that cecum is burst, spewing all of this, caustic material inside that peritoneal cavity. What do you think we need to do? Well, they're not going to be on complete bed rest because we're going to prevent complications. They're up and out of bed with pain medicine. They're going to get an NG tube because their intestines are angry. We need to keep it empty. IV antibiotics for the infection, and absolutely check that surgical site because it could dehisce, because it was dirty tissue put together, because that whole peritoneal sac is all been contaminated. Passage of urine, usually at night, in children who should have voluntary bladder control. And it's called anuresis. Now, there's two conditions here that I want to mention: epispadias and hypospadias. Epispadias is when in a male, The urine doesn't come out the tip. The urethra doesn't come to the end. It goes on the top, somewhere on top of the penis. That's where the hole is. There's no opening on the end. Hypospadias is somewhere on the bottom, okay? Underneath somewhere. And by the time that they're going to be potty trained, so before they're 1 year old, they need to keep their foreskin. They cannot be circumcised because we need that skin to open up the penis. We put in a catheter and we do a surgical closure using that extra skin. Postoperatively, they're going to have that little tiny catheter there. We do nothing to it. We just keep it inside a diaper so you don't get urine everywhere. And about 7 to 10 days later, they remove it. This is general anesthesia. This child goes to the surgery. They literally fillet open their penis to do this. So it's a big surgery, but the outcomes are usually pretty good. And they, of course, do it before potty training. A multi. What's Hirschsprung's disease? Hirschsprung's disease is that big outpatching of tissue, intestines, large intestines that does not work. There's no nerves in it. It's aganglionic, and it causes a congenital aganglionic megacolon. Remember, it could have a little squirt of little ribbon stool because there's only a tiny little end there, but it's basically no nerves. It's a megacolon and it needs treatment. And we'll treat it with usually a colostomy, remove that bad stuff, or we'll do that pull through where we can put it down to the anus in one stage. A multi. When teaching parents about Hirschsprung's disease, the nurse would include so it is a bowel obstruction. Usually it's at 2-stage surgery. And we're going to have to be monitoring those bowel habits because we've manipulated the bowel. So making sure that it keeps going. We do not use laxative and enemas in children. We try to do it through diet. And actually, the most I've ever seen given is something called Miralax, which is like Metamucil in the adult world. But we don't even like to do that. We try other things first. What type of stools would an infant with Hirschsprung's disease have? So this is those little ribbon stools because it's a little tiny little anus that it has to go through. Yes, very good. What is the condition that occurs mainly in children where the intestines telescope into each other? It goes and sucks in. And it's called an intussusception. And hopefully it'll pop out by itself. Many times it doesn't, it's stuck and it's swelling that keeps it there. Many times the air or barium enema will pull it out. And as I said, I've only seen one have to go to surgery for a colectomy, piece of the intestines taken out. Gastroesophageal reflux disease, GERD. What's that? And that's when the stomach, the insides goes up and it goes into the esophagus and it causes burning in infants, some spit up, losing nutrition, and older children. It could be that chronic cough and that pain and that burn. IBS, inflammatory bowel disease, involves what? And it's any part of the intestines. Remember, it says mouth to anus, any in the intestines. Absolutely. What would the nurse be looking for when a patient has Meckel diverticulum? Remember, that's in the small intestines, is that little out patching, it's a diverticuli, and it's got a big blood vessel in it, and it rips. And you may not see any outward pain, maybe slight tenderness around the belly button, but it's the painless rectal bleeding, is what they say. A 6-year-old child goes to the ER due to abdominal pain, fever, vomiting for the last day. What assessment is priority? And it's where is that abdominal pain? Is it an appendix? Is it an ulcer? Is it something that I need to treat quicker than the other? So, where is that pain? Makes a big difference. What would the nurse expect to see in an infant with biliary atresia? Well, when the biliary duct from the liver to the small intestines and the duodenum, it's clogged, it's closed. There's no liver bile dripping in there. What would you expect? Well, they're going to look like that baby. They're going to be jaundice, right? But there's no bile in the stool. And that's when you're going to see, and it's not going to be any fat digestion. So the stool's going to be pale looking, clay colored, and then no fat digestion, abdominal distension. Always fat in those children who can't tolerate it, abdominal distension. What structure of the mouth can be impacted by cleft lip and palate? And it's anything lip, palate. One of the things of seeing a child, an infant, a new infant with cleft lip and palate, is being there to support the parents because, the whole thing is open and it doesn't look very nice. So focus that mother's attention to, oh my goodness, look how much hair they have, or wow, that your little boy's got big feet. Something else. Don't, stress upon that and just say, don't worry, we'll fix it. Remember, moms are hormonal. They just had a baby, and sometimes they know, sometimes they don't. Cleft lip repair is typically done when? We want to get that lip closed as quick as we can because how does an infant, soothe themselves? It's all about their mouth, all oral, and then feeding. We need to get that lip closed. So 2 to 3 months is when. And they got to really do plastic, making closures. They have to approximate those edges so well so that in the future you don't have a crooked lip, especially girls and lipstick. Very important. When does cleft palate repair typically occur? It's somewhere between 6 to 12 months. The lip is first, then they go ahead and they do the palate. Esophageal atresia. What is that? Remember, A is without. Atresia is no opening. Esophageal atresia, there's no opening from the stomach to the esophagus. So food will go down, milk will go down, and it will come back up. And they usually will even just aspirate with esophageal atresia. What are the classic signs of esophageal atresia and tracheoesophageal fistula? So they swallow, it goes down into the lungs, goes down into the esophagus, directly to the lungs, goes into the esophagus, comes up, and they aspirate it. It's all about aspiration pneumonia. So cyanosis, choking, coughing. And they usually find that right after birth, or at least with the first feeding. Multi-select. A neonate with suspected tracheoesophageal fistula, nursing care should include we want the head of the bed elevated. We are not feeding these children because it will go directly into their lungs. So nothing by mouth. Suction at the bedside to keep that mouth, as free from mucus as we can. And because they're having many aspirations, we'll give the IV fluids because they're NPO and antibiotics because of those mini aspirations. A 5-year-old child is complaining of epigastric pain and a persistent cough. What would you suspect? And that's GERD, that's gastroesophageal reflux. Older people can get it. I mean, adults get it, children can get it, and we see that in infants through the spit up. What is ranitidine used for in a child with a peptic ulcer disease? It's not, it's famotidine now, which is Pepcid. We don't use Zantac, but it's in the book, so I put it here. Years ago, it used to be cimetidine, and we don't use that one either. So all it does is with the stomach, the ulcers due to an oversecretion of gastric acid, and it's burning the lining of the stomach, so it reduces it. So decreases the chance of that acid hurting that stomach. Signs and symptom of a hypertrophic pyloric stenosis. Remember, osis is a narrowing. Atresia is a nothing. Those are two words you need to remember in many things, in cardiac and in GI, right? So this is the one where they're vomiting across the room forcefully. And if you take your hand and put it underneath that xiphoid process, to the right, to the middle, right in that area, you will feel what we call an olive. I call it a marble because it is hard. And you can feel that pyloric stenosis. You can feel the hypertrophy of it. Signs and symptoms of hypertrophic pyloric stenosis are is so if you can imagine, these kids are eating, eating. It doesn't go down, and all of a sudden it comes up. And the kids are crying constantly to eat. They're hungry because nothing is going down to be absorbed. So projectile vomiting and being hungry, crying to eat, not poor. Preoperative treatment of pyloric stenosis includes NPO, start IV fluids, absolutely nothing to eat by mouth because all they're going to do is vomit, and you want to prevent any type of aspiration. What does the celiac disease affect? Remember, celiac disease is a nutritional problem of gluten. With that being said, what's affected? And it's the small intestines, okay? Digestion occurs, all of the enzymes are secreted into the small intestines, so celiac is still small intestines. If you have celiac disease, what should you eliminate from your diet? And it's just wheat, rye, barley, oats. You can have all the dairy, vegetables, chocolate, sweets, all of that you can have. The problem is anything breaded, and you have to be very careful about the breads and whatnot you have. Only rice. It cannot be, or a different flour that's not wheat, rye, barley, or oats. And remember, kids, those chicken nuggets are covered with breading. They can't have the breading either, or macaroni and cheese. A multi. Vitamins that children with celiac disease are prone to lose. A, D, K, all your fat vitamins on this one. Vitamin C is water soluble. So the other ones are fat, and these probably need to be replacements because they're not digesting them. Remember, that's why you have those malodorous, bulky stools that are coming out. And why? You should have more high protein and high carbohydrate diet and low gluten. What foods would you select for a child with celiac disease? Very good. It wouldn't be French toast because it's bread. It wouldn't be fish sticks. They're breaded plus macaroni and cheese. And then roast beef has garlic bread. So an omelet, banana, glass of milk, ice cream. Yes, all of that is fine. Anything with breads, no. Phimosis. Didn't cover it, but this is a little male. This was my grandson at birth. So phimosis is when the foreskin is so tight and restricted, you can't pull it down. You can't clean it. And being a pediatric nurse, my grandson lived with me at that time. Of course, I was telling the mother to pull it down, and she said, I can't. I tried. I'm like, it's stuck. So, in prevention of urinary tract infections, she opted to go get him circumcised at 1 month old because of that real, and it's tight. And we don't want to have any infections because of that. What is a hydrocele? This is another thing that children and adults of all ages can get. It usually will cause an incontinence and pain in the testicles. And what it is just there's a lot of fluid around the testicles, and they give a broad spectrum antibiotic for it, and it usually will resolve by itself. Hydrocele. What's cryptorchidism? Again, something with the males. Has something to do with the testicles, as you can tell. So usually at birth, both testicles are down and they're in the scrotal sac. One of the things that the pediatrician does at the first visit in a male is to make sure both testicles are sitting there. And sometimes it could take a couple months for it to come down, but they don't want that testicle to sit up in the abdominal cavity because it's too warm and it will actually destroy the sperm cells for later on in life. So they want it to come down. So cryptorchidism is failure or incomplete testicular descent. Now, males and their testicles, when they're cold, they shrink up, okay? When they're warm, they relax. So how would you examine an infant, a male infant that you're examining the testicles? In a warm room, right? You want them to be as low as they possibly can be. So you suspect an infant with cryptorchidism. How would you examine this infant? Another thing that you would do is, have you ever seen the testicle down before? And that does make a big difference. And something the nurse and the physician will ask. So again, have them in a nice warm room so the testicles will sag as best as they can to see if they are down or really are still up in the abdomen. Hypospadias. I told you earlier what that was. So this is what's known, what's ventral and dorsal, right? Dorsal on the top, epispadias. Hypospadias is ventral on the bottom of the penis. And it's just, it doesn't go to the tip. It comes out somewhere on the side. A multi-select. How's a hypospadias corrected? You know, they really like to do this before they're potty trained. Can you imagine they try to put their penis in the toilet and it comes out the other side? So they use the foreskin and they literally fillet the penis open, create a cavity, put a catheter or a stent in there, close it up using the foreskin tissue, and then they leave that catheter in there for 7 to 10 days. And they do really, really well. Again, general anesthesia, the penis is filleted open. What is a bladder exstrophy? It's like that gastroschisis or omphalocele, but it's the bladder this time. I've seen one of these, and I've seen quite a few omphalocele or the gastroschisis. Bladder exstrophy are more rare, but what it is it doesn't close. The bladder's born up on top. What is our big deal with this? Well, again, you've got tissue on the outside. You need a wet, sterile dressing to keep it moist, and you need to protect the skin. And again, they'll slowly get it put back in. The bladder still works the way it should. You still urinate the way you should. It's just on the outside of the body. What is a priority nursing care for an infant with bladder exstrophy? Priority nursing care. Keeping that tissue integrity as best as we can, again, with that normal saline and then monitoring that area, keeping it as, the tissue as well as we can. What are the clinical manifestations of nephrotic syndrome? Remember, has nothing to do with renal failure. Kidneys are working. So, nephrotic syndrome, your kidneys say, ugh, protein, I don't like you, and just urinates all the protein out of your body. It urinates it, so you see proteinuria. It loses the protein from the blood, so you have hypoalbuminemia because albumin is protein. And, these are things that will say low serum albumin. And of course, all of the fluid goes extrastitially, and these children generalized edema that you will see. Children with nephrotic syndrome are often given what medications for fluid overload? Well, when you think of it, you're talking about all that tissue extracellularly. How are you going to pull it into the vascular space and get rid of it? That's what this question is answering. What could that be? Well, you have a protein deficiency. So you're going to give albumin. Albumin is protein. Put it back in the space, and it sucks out the fluid from the extracellular space and puts it back into intravascularly. And then afterwards, you hit it with some furosemide, some Lasix, and it will cause it to urinate out all that extra fluid that's accumulated in that generalized edema. That's a really hard concept to understand, but you've replaced the protein now. It's now more isotonic and it's sucking the fluid out, and then you get rid of it. What is used to treat nephrotic syndrome in children? Besides diet, fluid restriction, and that's prednisone. Prednisone is also used for it, in those acute stages. And then to get rid of fluid, they're hospitalized. Of course, the albumin and the furosemide, and that will help get rid of fluid too. And how do we monitor that if it's working? Intake, output, daily weights. Anything with fluids, intake, output, daily weights. A child is admitted with acute glomerulonephritis. What recent illness could validate this finding? And that's a strep infection or a recent sore throat. They didn't know what it was. But glomerulonephritis is another strep, like rheumatic fever, glomerulonephritis. Same thing. How do we treat it? Well, symptomatically, also with glomerulonephritis, but also antibiotics to treat it. What's priority nursing care of a child with nephrotic syndrome? Priority. What do you need to monitor here? And that's daily weights, intake, and output. Again, we'll be limiting fluids and we will decrease that salt, right? We're going to have a low sodium diet. Why is erythropoietin used in chronic kidney failure? Remember, normally the kidney secretes erythropoietin, which normally just makes the red blood cells. In chronic kidney failure, we don't have it. So we need to give them the erythropoietin in a subcutaneous injection. It increases production of red blood cells. And because these children will have a really low hemoglobin hematocrits. So this helps decrease the amount of blood transfusions because they will be getting them. A multi. A child with chronic kidney disease can have renal osteodystrophy. What can this do to a child? It has to do with the vitamins and the calcium and all of these things. And it causes osteodystrophy. What is that? It causes, dystrophy or, abnormalities, skeletal abnormalities. It also has to do with high parathyroid. It has to do with the calcium in the body. And then, of course, if your bones aren't growing the way it should, you don't have the proper type of calcium, you'll see a growth retardation in it too. Uric acid, yes, has to do with kidneys, but it's not talking about osteodystrophy. It has nothing to do with bones. A diagnostic finding of acute glomerulonephritis may be what? And it's what we call an ASO titer. Look at the word and how it's spelled out. What's in the middle of the anti-streptolysin? It's positive strep in the blood, anti-streptolysin. When you're looking for strep, whether it's rheumatic fever, glomerulonephritis, an ASO titer, that's what it is. It looks for strep. Which complication of peritoneal dialysis is most important? What are you going to be looking for the most? And it's all about protecting that abdomen. You have no kidneys, they're not working. You only have a peritoneal cavity. You do not want that infected because then there's no way to filtrate that blood, especially when you're talking infants. They don't get hemodialysis. There's too much swishing of blood flow for the brain. It can cause a lot of brain bleeds and like hemorrhages in the brain. And those are not beneficial at all to the infant. So abdominal peritonitis, what would you see? A colored change, maybe excudate in there. Something's different in the fluid. That's what we're seeing abdominal peritonitis. You might even see redness of the abdomen, maybe. What clinical assessment is most important to report with a child diagnosed with an acute kidney trauma? You know, I had this little 9-year-old boy come in who was playing hide and seek. And he ran around a corner, was going sort of backwards, and his left mid back hit the trailer hitch on a trailer. And he came in with this huge ecchymotic area on his kidney area. His potassium was 7.6. It's like the spewing of potassium with the trauma. So he had a cracked or ruptured kidney. So he was admitted, but it's the potassium that showed us what was going on. Okay. Kidneys, potassium, they go hand in hand. A multi-select. What should the nurse anticipate for a child who just had a renal biopsy? So we had a biopsy on our kidneys. What do we need to watch? Well, absolutely. We're going to make sure the kidneys are working, intake and output. We're going to look at the dressing. Is it oozing urine? Is it oozing blood? We're going to look at the abdomen, abdominal distension, pain. And these children are on bed rest for 24 hours, just like a cardiac cath. They are not out of bed. It could, again, dislodge that clot and create problems of bleeding or urine going in, peritoneal cavity. So no ambulation, bed rest 24 hours, pressure dressing, monitor it, intake and output. What would you do if the fluid draining from the peritoneal dialysis has changed color and is now cloudy? Absolutely notify the provider. We are going to give antibiotics, but you can't write that order. Notify the provider. Very good. And last question. What would the nurse provide to an infant who cannot eat normally? How about that child with a tracheoesophageal fistula or esophageal atresia? They can't eat. What do they need? A pacifier. You're going to put nothing in that child's mouth that can't eat. Not milk, not water, not nothing. You need to give them that pacifier for normal growth and development. They relieve that stress by sucking. A pacifier is very important. That's how we did today. Turbo. Good job, Turbo. Miss Fig, good job, Miss Fig. And number 1. Oh, my initials again. I did good job. KK and not Blob, okay? All right, remember this week, send me your projects as you get them. You can do them piece by piece, whatever works for you. I'll send you back some insight to try to help you so that you can get the best grade you possibly can. All right?
Can I ask you a question?
Sure, absolutely.
Would you be willing to look how I